the SERAPHIN trial was, your classic randomized, double-blind, placebo-controlled, event-driven trial. So cardiologists are very familiar with that. Basically, the study is designed until a certain number of events are reached, and you power it based on historical studies looking at event rates for whatever the subject is of interest. We won't bore you with all the inclusion criteria, but clearly these were sort of standard PAH patients. We did allow certain background therapies, which also is quite important when we look at the results of the study, but it had to be a stable dose for at least 3 months. So some of these patients certainly, and we've had some our posters looking at this, could be relatively newly diagnosed patients, and a number of them were really truly prevalent patients with the disease for quite a long period of time. So the primary endpoint was what we call a morbidity mortality event. And again, you're all, I'm sure, very familiar with these data, but this was a very, I think, powerful endpoint, and in some ways maybe a risky one. But this was a combined endpoint, or composite endpoint, of time to first event, which included death or atrial septicemia or lung transplant, initiation of IV or sub-Q prostanoids, or worsening of PAH. And worsening of PAH was defined as really a multi-pronged manifestation of worsening. So a confirmed decrease in walk distance, as you can see there, worsening of symptoms, and you can see the definition there, so functional class or other symptoms developing of right heart failure, and you notice the ands, not the ors, and the need, in the opinion of the investigator, for additional non-parenteral therapies, such as oral and inhaled therapies, PD-5 inhibitors, et cetera, or IV diuretics. So all of those criteria had to be met for a patient to be considered as having worsening of PAH. So there are a lot of sort of checks and balances. And that was the primary endpoint, with the vast majority on a PD-5 inhibitor of those patients on background therapy. So a good 60% of patients receiving mostly sildenafil, some tadalafil, when they enrolled in this study. The final results were that 287 patients had a primary event with a mean duration of treatment of a little over 2 years. So that's certainly a dramatic difference from the previous trials that had been done in pulmonary hypertension. And you can see the breakdown of the absolute number of events and percentages in each group, with clearly more events occurring in the placebo group. When we look at the statistics and the significance of that difference, one can see that for all events, a hazard ratio for 3 milligrams of 0.7 and 0.55 for 10 milligrams. So a 30% risk reduction and a 45% risk reduction throughout the trial. And you can see the breakdown of the individual components of that event. Not at all surprisingly, much of that event was driven by worsening PAH. When you look at the Kaplan-Meier curves, you can see here the separation occurring fairly early and continuing throughout the duration of the trial. When we looked at a couple of the specific components or additional data points, such as death due to PAH or hospitalization for PAH, we also saw some significant effects. This is a pre-specified secondary endpoint of this study. And what we found was that, and you can see the numbers here, that at the approved dose of 10 milligrams, we had a hazard ratio of 0.5. So 50% reduction in death due to PAH or hospitalization due to PAH. So highly statistically significant at 10 milligrams and also significant at 3 milligrams compared to placebo. So there was a reduction in death or hospitalization specifically due to PAH. Other secondary endpoints included 6-minute walk distance and functional class, and those were both significantly benefited from asatentan, with the 10 milligram dose providing this sort of an increase in 6-minute walk distance. Placebo patient, not surprisingly, worsened over the course of the study. Again, this is a long-term study. This was an assessment at 6 months. And functional class, similarly, more patients on the treatment had improvement in functional class than patients who received placebo. So consistent effects looking at improvements. So when we look at adverse events, no real surprises there. And you look at placebo versus drug, and you can kind of see visually the differences in adverse events that were reported. Draw your attention to the fact that peripheral edema was not any significant between placebo and 3 or 10 milligrams of macitentan. Nasopharyngitis, somewhat more common. Headache, somewhat more common. No real surprises. The one that does draw some attention is anemia, and there were more patients on the treatment arm, and this seemed to be a dose-response effect, that had reduction in hemoglobin, as those of you who participate in the study, I'm sure, are well aware. Although the clinical significance of that anemia appeared to be minimal, and I believe only 3 patients, 1 in each arm, had to be withdrawn from the study due to anemia. So it didn't appear to be a treatment-limiting adverse event, at least in the trial, but something that does need to be monitored. So in conclusion, what we can say is that macitentan significantly reduced morbidity and mortality among patients with pulmonary hypertension in this novel, event-driven study, that the drug was certainly well tolerated, and there was no signal for liver toxicity. And I didn't point that out, but that was obviously an important finding that you're all very well aware of, is that placebo patients versus treatment patients, there was no difference in any of the parameters of liver toxicity, and for that reason, monthly requirement for liver monitoring was not present and is not present with macitentan. And several of the secondary endpoints were also beneficially affected by macitentan, which is now available at 10 milligrams once a day, single dose.
So this was a global phase 4 prospective randomized double-blind add-on placebo-controlled event-driven trial. A lot of words there. I think one of the most important things about this is a phase 4 trial. It was sort of real world. It was not a registration trial. And so we, at the time of the design of it, we took a little bit more sort of relaxed approach to try to make it more real world and make it easier for the investigators. The primary endpoint was time to first morbidity and mortality event. This is the study design. The patients had to be on sildenafil at a dose of at least 20 milligrams 3 times per day, stable on that for 12 weeks. And then they were randomized to either bozetin or placebo. There were additional secondary endpoints monitored at 16 weeks, the hall walk and functional class. There was a variable amount of treatment depending on when they entered the study and when the study closed or if they had an event. And the study went on until we had 156 events. There were 377 patients that underwent screening, 334 randomized, 175 to placebo, and 159 to bozetin. But out of those patients that were randomized, 89 of the 175 in placebo were prematurely discontinued, and 83 of the 159 in bozetin were prematurely discontinued. So you can see there's a large amount of patients who didn't finish the study, didn't hit an endpoint. Over the nearly 8-year duration of the study, there were 63 that discontinued without having experienced a primary endpoint. And overall, there's about 20% missing data for the primary endpoint. Here is the efficacy result, the Kaplan-Meier curves for the time to first morbidity and mortality event. There's no difference between those curves. They're almost superimposable, risk reduction of 17%, non-significant p-value. So this study did not meet the primary endpoint. It's a neutral study. If we go on and look at the distribution of the primary endpoint events between placebo and bozetin, you can see there's none of this is significant, so we're not going to make any more here or less here, but worsening of PAH accounts for the majority of the endpoints in both groups, some hospitalization for IV therapy, and some deaths in both of the groups. So safety and tolerability, this is obviously a drug that we know well. We've been using this drug for over a decade. There is a large number of patient months exposed here, so it's a rich safety database. As we see commonly in PAH trials, there's a lot of adverse events, and obviously this trial lasted for a very long time, so you can imagine the number of AEs and SAEs that have occurred over time. The rest of the adverse events, or the specifics of the adverse events, are listed here. And as you can expect, many of them are due to worsening pulmonary arterial hypertension. This is a long duration study. Edema, dyspnea, many PAH-specific things. There are side effects that we know can be attributed to the drugs listed here, edema, anemia, and the like. There's really nothing that stands out here that we don't already know about bozetin. And then the LFT abnormalities are listed here. Now, remember, this is a trial that is much longer in duration. The LFT abnormalities that we see in the package insert are from Breathe 1, which is 16 weeks, from Early, which is 6 months. So this is a longer duration of exposure, and you see that about a little over 20% of patients had LFT abnormalities greater than 3 times the upper limit of normal, about 5% greater than 8, and there was a reduction in hemoglobin less than 10 in a similar, about 9% in each group. So it really is very similar to the safety profile of bozetin that we already know. So to sum that up, COMPASS 2 did not demonstrate that adding bozetin to sildenafil in this study was superior to sildenafil monotherapy in achieving the morbidity and mortality endpoint event. Again, interpreted with caution because the primary endpoint was negative, but there were some treatment effects noted in the 6-minute hall walk and NT-proBNP, but no difference for any other efficacy endpoint. The safety profile was consistent with that known profile of bozetin, and there were many limitations for this study, and I think this is really what we need to focus on for the purposes of our discussion today. A ton of limitations. Remember, this was actually the first morbidity and mortality type study that we started. I mean, SERAPHIN reported out before this, but this actually started before SERAPHIN. We were new at designing these trials. The investigators were new at doing these trials. They were used to doing 12 and 16-week hall walk trials. So the discontinuation rate was a huge problem with this trial. The primary endpoint components, as I've mentioned, we tried the patient global self-assessment because we wanted to move in the direction of taking the patient's symptoms more into account, but perhaps that was the wrong thing to use in this study. It hadn't been previously studied in pulmonary hypertension patients. The statistical assumptions changed over the course of the study. You know, when we started, it was a 600 or 800 patient study, and it was clear that it wasn't feasible. It was clear that new data was coming out, and so those changed, and the study got smaller, so that may have impacted things. The patient profile was a little problematic. We were trying to make this a real-world study. It's a phase 4 study. We were trying not to torture investigators and coordinators, and weren't requiring as much of the source documentation as many of the actual PFTs, cath, all of that, as many other registration studies did. And as a result, I think we got some patients who may have formally met entry criteria, but we might look at them and say, gosh, I really don't think this is a group 1 PAH patient. So there are many limitations that I think can be learning opportunities for future studies.
Ambition is, I think, in part the natural progression in that it too is a morbidity mortality study. But as you'll see, rather than clinical worsening being the sole element of the primary endpoint, treatment failure was also considered as part of the composite endpoint. In other words, not getting worse is good, but it's not as good as getting better. And so we incorporated parameters of treatment failure as part of the endpoint of that study. And this too is a post-marketing study in that every patient who enrolled in Ambition received an approved therapy for pulmonary hypertension. So the study characteristics were that this was a phase 3/4 randomized double-blind multi-center study, and the objective was to compare safety and efficacy of first-line combination therapy using 2 approved drugs that target different pathogenic pathways, ambrisentan, an endothelin receptor antagonist, tadalafil, a PDE5 inhibitor, to compare that with a strategy of first-line monotherapy, either the ERA ambrisentan or the PDE5 inhibitor tadalafil, in treatment-naive incident patients who were functional class 2 and 3 pulmonary arterial hypertension. But the question is upfront combination therapy targeting 2 pathways better than starting with monotherapy targeting 1 or 2 pathways? So the primary efficacy endpoint is time to first clinical failure of PAH, and that was defined as death, hospitalization for worsening, which also was event committee adjudicated, disease progression, as we've seen with SERAPHIN, a 15% decrease from baseline in walk, and a change in functional class, or at least being in functional class 3 or 4, as well as an unsatisfactory long-term clinical response, which was also adjudicated. And that means that they had to receive at least 1 dose of treatment and be in the study for a minimum of 6 months. They had to have had a decrease in walk test at 2 consecutive clinic visits separated by 2 weeks apart, and remain or worsen to functional class 3 symptoms for a minimum of 6 months. So these are clearly patients who have not achieved what we would consider a satisfactory response to medical therapy. Primary endpoint, this is the Kaplan-Meier curve, time to first clinical failure. This is combination therapy. This is the primary analysis pooled monotherapy. The hazard ratio is 0.5 with a highly statistically significant difference in favor of combination therapy. If you look at the forest plot of the first adjudicated clinical failure by subgroups, you can see that across the board, whether it's etiology, severity of disease by functional class, age, baseline 6-minute walk above or below the median, geography, or gender, all of these were in favor of combination therapy. If you look at the components of the first adjudicated clinical failure event, there were very few deaths, which is not uncommon. And I'm often asked about this, and let me remind you that it's not that people in these studies don't die, but death is not often their first event. They often get hospitalized because of worsening, or they get started on epoprostenol because of worsening. That's their event as far as the study goes. If they subsequently die, well, that's important and that's captured, but that wasn't their event as far as their first event as the study goes. So this is first event. And you can see that this is largely or heavily driven by hospitalization for worsening PAH in this disease, in this study. Time to first adjudicated clinical failure, combination versus each individual monotherapy. This is ambrisentan. This is tadalafil, and so it's not like one drug was bad and as a monotherapy and that drove the results. Upfront combination beat each individual monotherapy individually and as a pooled analysis. We have really nice effects on NT-proBNP reductions with all the therapies, monotherapy and combination therapy, but the reduction with combination therapy exceeds that with monotherapy, and we observed 70% decrease in NT-proBNP with upfront combination therapy. If we look at the satisfactory clinical response, which was an improvement in walk of 10%, achieving functional class 1 or 2, and no events of clinical worsening. So not just not getting worse, but what percentage actually got better? And more patients with combination therapy actually met these improvement criteria at week 24 than the cohorts receiving either of the individual monotherapies. And if you look at the walk changes, there's an improvement that we're used to seeing with monotherapies. Again, there's no placebo arm here, so there's no placebo-corrected treatment effect. But you can see that with combination therapy, there's about a 50-meter improvement in walk compared to baseline versus about 25 with each of the monotherapies. In terms of safety, there were no major issues. Edema was common, as it is in all conditions, and generally manageable, and only a few patients actually withdrew from the study because of refractory edema. And I think that's just a matter of learning how to manage edema in these patients, be it from heart failure, right heart failure, or drug-related, as does occur with ambrisentan, or a combination of the two. The overall conclusion is Ambition is the first randomized trial to compare the effect on time to clinical failure of upfront combination therapy compared to upfront monotherapy in treatment-naive and incident PAH patients. And so it's not testing a specific drug per se, it's testing a strategy of treatment. It's the first trial to compare two treatment strategies. Upfront combination with the two drugs, again targeting two pathways, reduced the risk of clinical failure by 50% compared with pooled monotherapy with either drug alone in both the primary analysis set and the ITT population. And I think the important lesson is that we looked carefully at this population early on and made adjustments to the enrollment criteria that I think provided a more homogeneous phenotype. The main driver of the composite primary endpoint was a reduction in hospitalizations from 12% to 4%, and that's an important event in the life of patients with PAH. And among the supportive analyses, there was also a reduction in the risk of clinical events, of clinical worsening by almost 50%, significantly greater reduction in NT-proBNP with combination, increased percentage of patients achieving a satisfactory clinical response compared to monotherapy, and a substantially greater improvement in 6-minute walk. So these are comparisons to monotherapy rather than the changes alone.
Selexipag was first studied in a phase 2 clinical trial. This had 43 patients that were randomized 3-to-1 to Selexipag versus placebo. And typical PAH, here's the etiologies, mainly idiopathic connective tissue disease, functional class 2 and 3 patients, and they were all on background therapy. About a third of them were on 2 background therapies. They were treated for 17 weeks. There was a dose up titration, and these were the doses that were utilized in the study. This maximum dose, which was 4 pills twice a day, it comes as a 200 microgram pill, is half of what gets used ultimately in GRIPHON. And so the maximum dose here for the hemodynamics that I'm showing you, this is what patients were on at 17 weeks. So some on the lowest dose, about half the patients had reached the highest dose at 17 weeks here. And what they saw, primary endpoint was change in pulmonary vascular resistance, about a 20% improvement in the Selexipag group, some worsening as is often seen in the placebo group, with an overall treatment effect of about 30%. This is the per protocol analysis. They also present the intention to treat analysis, and it was fairly similar. It was actually a slightly greater difference between the two groups. Secondary endpoint was change in 6-minute walk distance at 17 weeks. This study was clearly not powered to evaluate 6-minute walk, but they saw a mean treatment effect of 24 meters with the placebo group not really changing, the Selexipag group increasing some. And as I said, p-value not statistically significant there. This, as we've been talking about this morning, is a time to clinical worsening type trial. Here are the endpoints. I'll show that again on my summary slide at the end. So that's the primary endpoint. Secondary endpoint were measured at 26 weeks, with the idea being that everybody would up-titrate for the first 12 weeks. You would then hold steady at that dose, and then at 26 weeks, assess 6-minute walk, Borg Dyspnea Index, functional class, and CAMP4. The other named secondary endpoint was time to death, all cause, which is important because if you have a PAH hospitalization as part of the primary endpoint, you're not eligible within the analysis. You don't count as a second event, and so this just is an important way to look at the overall trial results. Patients could be treatment naive or on one oral background therapy or on two. You just couldn't be on a prostacyclin, obviously. And the study was powered to end when 378 clinical events were reached. This is the up titration. So as I mentioned, the maximum dose that was allowed was twice as high as what was done in the phase 2 study. And patients were started at 200 micrograms. They were seen on the day they started. And then the up titration was done by phone calls. There wasn't any fancy, let's measure the blood pressure or do a whole bunch of it. Was just, how are you doing? Are you tolerating the medication very well? And if you are, then you went up. If you were not, you could hold at that same dose. And if you were having severe side effects, you could step down a level. And then at 4 weeks, another visit. At 8 weeks, another visit. And then by 12 weeks, you had to stop up titrating at that point. From that point on, you could increase again at 26 weeks and then every 6 months. The final sample size was over 1,000 patients. So you can see this is considerably larger than the other studies that we've been talking about. SERAPHIN was second largest with 700 something patients, and the others were down in the 300 and 500 range, so quite a bit larger. This was by design because with 80% of patients on background therapy, including a really sizable number on 2 background therapies, it wasn't clear whether the risk reduction was likely to be as large as if you were doing certainly treatment naive or patients on just 1 background therapy. Side effects, pretty typical what you'd expect for prostacyclin pathway, and discontinuation rate, not perhaps as low as we've seen in some 12-week clinical trials, but pretty good for the amount of time that patients were followed in this study, I think, overall. And then this is my only other results page, as we said, just the top-line results. The reduction in the primary endpoint, the time to event, was a 39% reduction versus placebo, which was highly statistically significant. And the only other information that we got is the statement that the efficacy was consistent across subgroups. And it was actually really, really consistent. So this included age, gender, PAH etiology, functional class 2 versus 3, and then treatment naive, 1 drug, and 2 drugs. So including patients who were functional class 2 or who were on 2 background therapies, the overall effect size was similar.